That's what Dr. Miriam Chen asked her 67-year-old patient Harold when she pressed a pin to his forearm. Harold looked down. He couldn't feel a thing. 6 months earlier, Harold had noticed tingling in his fingers, then weakness in his grip. He dropped things. He thought it was just aging. His family thought he was being clumsy. But Harold wasn't clumsy. Harold had a brachial plexus nerve injury, undiagnosed for over half a year, and by the time he reached a specialist, 2 of the muscles in his hand had already begun to permanently atrophy. Here's the terrifying part. Harold's story is not rare. According to the American Academy of Orthopedic Surgeons, upper extremity nerve injuries affect an estimated 1 in 50 adults over the age of 60, and the majority go undiagnosed for 3 months or longer. 3 months of silent damage, 3 months of nerves dying. And when nerve cells die, unlike muscle cells, they do not come back easily. If you have ever felt numbness or tingling in your fingers, hand, or arm, unexplained weakness when gripping, lifting, or reaching, a burning or electric shock sensation down your arm, or a loss of coordination you cannot explain, do not scroll past this video. Because in the next 10 minutes, I'm going to walk you through exactly how upper extremity nerve injuries are diagnosed, the motor tests, the sensory tests, the red flags, in language your doctor should have explained to you years ago. My name is Dr. James Holloway. I've spent 27 years practicing neurology and rehabilitation medicine with a focus on peripheral nerve disorders in aging adults. I've personally evaluated and treated over 4,000 patients with upper extremity nerve conditions, from carpal tunnel syndrome to full brachial plexus avulsions. In my clinical experience, the single biggest barrier to recovery is not the injury itself. It is the delay in diagnosis. And that delay almost always comes from one of 2 things. 1, patients don't recognize the warning signs early enough. 2, the testing is done incorrectly or incompletely. Today, I'm going to eliminate both of those barriers for you permanently. Let's start with the biology, because once you understand what's happening inside your arm, everything else will make sense. Your upper extremity, your arm, elbow, wrist, and hand, is controlled by a network of nerves that originate in your cervical spine, specifically from vertebrae C5 through T1. These nerves bundle together to form what's called the brachial plexus. Think of it as the main electrical switchboard for your entire arm. From there, 3 major nerves branch out and travel down your arm. The radial nerve, controlling extension of the wrist and fingers, the median nerve, controlling grip strength and thumb opposition, and the ulnar nerve, controlling the small muscles of the hand and the ring and little finger. Now here's what aging does to this system. After the age of 60, nerve conduction velocity, the speed at which signals travel through your nerves, begins to decline at approximately 1 to 2 meters per second per decade. That doesn't sound like much, but in practical terms, it means your nervous system's ability to detect touch, pain, pressure, temperature, and position is gradually slowing down. Add to that the compressive effects of cervical disc degeneration, arthritis, repetitive strain, or even a single traumatic fall, and you have a perfect storm for upper extremity nerve injury. The damage happens in one of 3 forms. Neuropraxia, a temporary interruption of nerve conduction, fully reversible. Axon of Metsis, the inner nerve fiber is damaged but the outer sheath is intact, partially reversible with time and therapy. Neurotemesis, complete nerve transection, requires surgery. Outcomes are poor without early intervention. This is why early diagnosis is not optional. It is survival for your independence. Arthritis and nerve injury can coexist, but they are treated entirely differently. Treating nerve damage as arthritis delays the correct intervention and accelerates muscle atrophy. The data. A 2021 study published in the Journal of Hand Surgery found that 43% of patients with peripheral nerve injuries in the upper extremity were initially misdiagnosed as having arthritis or tendinitis. Their average treatment delay, 7.4 months. Patient story. Margaret, age 71, was told her hand weakness was just arthritis for 8 months. By the time an EMG confirmed median nerve damage, she had lost 60% of her thenar muscle mass, the thick pad at the base of the thumb. She required surgery and 18 months of hand therapy to regain partial function. She still cannot fully button her left sleeve. When numbness or weakness affects only one arm or one hand, patients often rationalize it as sleeping in a bad position or overusing that arm. But unilateral symptoms are a red flag for focal nerve compression or injury, not fatigue. The data. Research from the Mayo Clinic indicates that unilateral upper extremity weakness presenting in adults over 60 has a nerve-related cause in over 68% of these cases, yet fewer than 30% of these patients sought evaluation within the first month. Patient story. Robert, 64, noticed he couldn't fully extend his right wrist in the morning. He assumed he had slept awkwardly. Weeks later, he had what clinicians call wrist drop, a classic sign of radial nerve palsy. Early intervention could have prevented it. It didn't happen because no one told him that wrist extension weakness lasting for more than 48 hours requires medical evaluation. Minor neuropraxia, the mildest form, often does resolve spontaneously, but patients cannot distinguish neuropraxia from axon of Metsis without clinical testing. Waiting and hoping for self-resolution with a more serious injury means weeks of ongoing nerve fiber death. The data. Nerve regeneration occurs at approximately 1 millimeter per day in ideal conditions. A nerve injury at the level of the shoulder may need to regenerate 300 to 400 millimeters to reach the muscles of the hand. That's nearly a year, if regeneration begins promptly and if the muscle hasn't atrophied beyond the point of no return. Motor testing evaluates the strength and function of specific muscles controlled by each nerve. In upper extremity injuries, we test 3 primary nerve territories. The science. When a nerve is injured, the muscles it supplies begin to weaken in a predictable pattern. By testing those muscles in isolation, we can identify which nerve is injured and at what level. Clinical data. Manual muscle testing graded on the MRC scale from 0 to no contraction to 5 to normal strength has a diagnostic accuracy of over 85% for localizing upper extremity nerve lesions combined with sensory testing. Specific action plan for patients. Here are 3 motor tests you can report to your physician or ask them to perform. Wrist extension test, radial nerve. Ask the patient to extend their wrist against resistance. Weakness or inability equals radial nerve compromise. Ask your doctor, can we test radial nerve motor function? Thumb opposition test, median nerve. Touch the tip of the thumb to the tip of the little finger and hold against resistance. Weakness equals median nerve involvement, often at the carpal tunnel. Finger abduction test, ulnar nerve. Spread the fingers wide against resistance, specifically the index finger. Weakness of the first dorsal interosseous muscle is a hallmark of ulnar nerve injury. Sensory testing maps the patient's ability to perceive light touch, pinprick, temperature, vibration, and 2-point discrimination across defined areas of the hand and arm called dermatomes. The science. Each nerve supplies a specific skin territory. Sensory loss in the radial aspect of the hand, thumb, and index finger points to median nerve pathology. Loss over the little finger and hypothenar eminence points to ulnar nerve injury. Clinical data. The Semmes-Weinstein monofilament test, a gold standard sensory assessment, can detect sensory nerve loss months before the patient reports symptoms. Studies show it identifies early peripheral neuropathy with 91% sensitivity in the hands of trained clinicians. Action plan. Ask your doctor specifically, Have you tested my two-point discrimination? The ability to distinguish two separate touches 5 millimeters apart on the fingertip is one of the most sensitive early indicators of peripheral nerve compression. Or, can we check my vibration sense? Using a 128 Hz tuning fork on the fingertips, vibration loss is often the first detectable sign of peripheral nerve deterioration. When clinical motor and sensory testing raises suspicion, the next step is electromyography and nerve conduction studies, the definitive diagnostic tools for peripheral nerve injuries. The science. Electromyography measures electrical activity within muscles. Nerve conduction studies measure how fast and how strongly electrical signals travel through nerves. Together, they can determine the type, severity, and location of nerve damage with a level of precision no physical exam can match. The data. According to the American Association of Neuromuscular and Electrodiagnostic Medicine, EMG and NCS studies have a combined